Okay, I'm going to go ahead and get us started here. First and foremost, thank you to everyone who has logged on and shown up to join us on a Friday evening. The California Thoracic Society is very excited that we can offer these educational webinars on Friday evenings, and a big part of that are the people who are attending to show up, ask questions, and be able to collaborate and communicate with our speakers. At the end of today's presentation, as we've always done, we will have an opportunity for a live Q&A with Tyler. The best way for you to facilitate a question is through the Q&A icon or button at the bottom of your Zoom interface. It's okay if you also need to use the chat functionality, if that's the only button you can find, but if possible, please use the Q&A, as that makes it easier for Tyler and I to facilitate the questions and answers and really keep the conversation going. So again, at the end of this presentation, Tyler will be available to field any questions you have. That being said, I want to start by introducing our speaker today. This is Tyler Weiss. Tyler is the Adult Clinical Education Coordinator and Assistant Professor for the Department of Cardiopulmonary Sciences, the Division of Respiratory Care at Rush University Medical Center in Chicago, Illinois. Tyler received his master's in respiratory care from Rush University and is currently a PhD candidate at Rush University, with his research focus as assessing prone positioning in intubated patients with COVID-19 utilizing lung ultrasound. Tyler has presented at numerous regional, national, and international conferences on various topics related to respiratory care. Throughout the COVID-19 pandemic, Tyler has worked on the front lines, caring for patients afflicted with COVID-19. He has multiple publications, most recently as lead author on a paper in the British Journal of Anesthesia on the effect of serial prone positioning sessions on intubated patients with COVID-19, as well as a paper in Critical Care Journal on strategies to prevent nosocomial infections in healthcare professionals caring for patients with COVID-19. In addition, Tyler recently published a manuscript of the implementation of a multidisciplinary prone team during a pandemic in the American Journal of Nursing. Due to his efforts during the pandemic, Tyler was named one of Chicago's 2020 notable healthcare heroes. Without further ado, we would like to introduce Tyler as he will begin this presentation. And we also wanted to take a moment to thank Fisher Paykel Healthcare. This was developed by the California Thoracic Society in collaboration with Fisher and Paykel Healthcare. Tyler, I will turn it over to you.
Thank you very much. And thank you to the CTS and Fisher and Paykel for having me tonight. So I have a lot of content to get through, so I'm just going to get started. We're going to talk a lot about prone positioning here. So what's new with it? Let me see. There we go. Just get it out there. I have no real or perceived conflicts of interest that relate to this presentation. I may speak of some brands. However, this is in no way to me meant to promote or endorse a product. It's just to illustrate a point of emphasis. We're going to talk a little bit about the rationale and current literature support for prone positioning ARDS, including COVID-19. We'll describe some methods and challenges of pacing patients in the prone position, as well as discuss mechanical ventilation management strategies for the patient in the prone position. So what is prone positioning? Well, I'm sure we're all pretty used to knowing what prone positioning is now, but it is simply just placing a patient on their belly. So why do we do this? Well, placing someone in the prone position can help alter the mechanics of the way that we ventilate the patient, and it can improve the physiology of gas exchange. And what it really does is it helps reduce the dorsal lung compression. And I'll talk about this in a few slides here coming up. And ultimately, it helps improve lung perfusion, which then helps improve oxygenation. So in the supine position, we have this increased regional pressure at the bottom of our lungs. So in our dorsal regions, the area of the lung that is at the bottom of our lung when we're supine has a lot of vertical pressure coming on from your body habitus, the organs, your heart, and that tends to compress lung tissue. which then leads to a low VQ, so a perfusion and ventilation mismatch, which increases the shunt, which then decreases your oxygenation. And then the areas of the lung that are open, so your ventral region of the lung tends to become more overdistended, and you have this cyclic opening and closing of alveoli, which, as we know, leads to lung injury, which is not good. So here, this is a depiction of what your ARDS lung looks like on CT typically, and this is what I was talking about. You have this dorsal region, which is compressed lung, completely gasless, and then we have what Gattinoni famously described as the baby lung, which is essentially just the well-ventilated area of lung that is not being affected by the dorsal the compression of your habitus or organs. So this gasless compartment here is what really leads to our VQ mismatch, because most of our blood flow occurs in the dorsal region. So when we place someone in the prone position, we're essentially trying to reverse all the things that I spoke about in the supine position. So we do this to decrease the alveolar overinflation and also to reduce the alveolar collapse we see in the dorsal region, which then in turn will hopefully decrease lung injury. Also, by placing the patient on their stomach, it alleviates the abdomen, the organs such as the heart, to promote lung recruitment, and all this essentially leads to improved VQ matching, which will then turn into better oxygenation. And as I said previously, perfusion tends to persist dorsally, even when we place the patient in supine or prone position, there is usually a theory that due to gravity, blood flow then would go to the well-aerated ventral region, and that's why we have improved VQ matching. However, it was found that blood flow actually tends to stay in the dorsal region, so along the back. And as those lung units open up in the prone position, our VQ mismatch improves, leading to better oxygenation. And this is a depiction of exactly what I was just describing. So over here on the left side, we have that dorsal lung unit, which is compressed in the well-ventilated ventral region of the lung. And what happens here is, because these ventral lung units are very well aerated, we have very high transpulmonary pressures here, whereas in the dorsal lung region, we have very low. So it's a very heterogeneous way to ventilate a patient, and it can lead to injury. And again, down here in the dorsal region is where all the blood flow is happening, and that happens to be right where there's no ventilation. So that is the pure definition of a shunt. We have perfusion without ventilation. So by flipping the patient onto their stomach, it helps create this more homogeneous ventilation by having more evenly distributed pleural pressures across the ventral and dorsal regions. And again, the blood flow persists, which in the now ventral portion of the lung as the patient is prone. And as those lung units open up from being prone, the oxygenation improves. So prone positioning is not new, so why now? Well, I think the very simple answer now is COVID-19. When I created this presentation back in 2014, I've slowly been adding to it year after year. Back then, people weren't really proning. Even a couple years ago, we weren't proning all that much. So why did it take a pandemic? Well, we know that there's been several past studies, randomized control trials, that show that proning does improve oxygenation. In fact, up to 70% of patients respond with improvement in oxygenation, which allows us to reduce FiO2. So that's good. Also, there's been several studies that have shown that prone position can prevent ventilator-induced lung injury, which is, again, very good. But still, people weren't doing it. And the reason why is because in most trials, the physiologic benefits did not translate into a better outcome. So there was really no improvement in survival or mortality. That is until 2013, where Guerin et al., they published the Prosiva Trial, which is the landmark trial that put prone positioning back on the map, and it did indeed show a mortality benefit in those that were prone versus those who were supine, compared to the previous studies in 2009, 2006, 2004, 2001, where there was no significant impact on mortality. So in 2013 is when prone positioning was back on the map, but yet, I repeat, we still did not prone all that regularly. People were still scared to do it. So this is the Prosiva trial, which I'm sure you guys are familiar with. If you're not, highly recommend looking at this study. And really what it was is they really looked at what they already knew. Over the last 30 years, the past 3 decades, prone positioning has been used to treat hypoxic respiratory failure. We knew that it helped VQ matching. We knew that the pleural pressure gradients became more homogeneous and the compression of the lung volumes from the heart and abdomen was reduced. And we knew that it improved oxygen and reduced ventilator-induced lung injury. So they did this study because of that mere fact that it continued to show no mortality benefit. So they wanted to prove that there was a mortality benefit. And this was a prospective multi-center randomized control trial in 26 ICUs across France and 1 in ICU. All ICUs had at least 5 years prone positioning experience, which is something important to take note of. And they included patients with severe ARDS, utilizing the American European Consensus Conference criteria. The Berlin definition was not yet defined when the study was being conducted, so they used the American European Consensus Conference criteria. The criteria was endotracheal intubation for mechanical ventilation for ARDS within 36 hours, and severe ARDS with a PF ratio less than 150, on a FiO2 of at least 60% and a PEEP of at least 5. And the key here is tidal volumes of 6 mLs per kg predicted body weight. So I'm going to bring you back to this table just to show you that this was a big factor in why we believe that this study showed a mortality benefit. All the other previous studies were not using lung protective ventilation. So in 2001 and 2004, they did not use it. 2006, 2009, they had tidal volumes less than 10 mLs per kg. However, in 2013, Guerin and colleagues standardized the treatment to 6 mLs per kg ideal body weight across both groups. And then that is when we saw the mortality benefits. So some may say that they found the recipe. And you can see here at the 28 and 90-day mortality, the supine group at 28-day was 75% mortality compared to a 38% mortality in the prone group, which just numbers alone is remarkable. So from this came a lot of guidelines. And this was published in 2017 in CHEST. And they looked at all the clinical evidence, and they recommend proning patients with severe ARDS early in their course for a long duration, at least 16 hours a day, and then discontinue the prone positioning when you meet minimal ventilator requirements. And we'll talk a little bit more about when to discontinue proning. And then again, coupling this with lung protective ventilation strategies as well as experienced staff. So again, all that, those are all part of the recipe, in my opinion, on why the Prosiva trial was a success. And I'm not going to read through all this, but this study also showed just some recommendations for prone ventilation. So who to prone? Again, those patients in severe ARDS early in the course and utilizing 6 mLs per kg. How to place the patient in the prone position. We'll talk about that as well. But it is a little labor intensive, but as you do more and more of it, it tends to get pretty easy, actually. How long to prone a patient? So the Prosiva trial did, their average was 17 hours, so at least 16 hours. There's been recent literature in COVID-19 of proning patients up to 36 hours. So for a longer period of time. This also has contraindications. Obviously, anyone with unstable C-spine injury, spinal instability, facial trauma, anything like that, you would want to watch out for. There's obviously a myriad of complications that can occur. This is not a benign process. There's obviously critically ill patients with lines and tubes. So you want to make sure that there are you're aware of these complications. And then when we stop, it's typically when a patient can tolerate being supine and maintaining their PF ratio greater than 150 on a PEEP less than 10 and an FiO2 less than 60. So essentially not meeting the criteria that was defined in the Prosiva trial. And again, just some more guidelines. This is from the ATS and European Society of Intensive Care and SCCM in 2017. Their recommendations for mechanical ventilation for patients with ARDS, should they receive prone positioning. Obviously, once the Prosiva trial was published, they do have a strong recommendation with moderate to high confidence that patients with severe ARDS should be prone for more than 12 hours a day. And then this one I really like. This was published in 2019, and this is just a formal guideline of how to look at your patients with ARDS. And essentially, it starts with you intubate them, you put them on lung protective ventilation, you screen to see if they meet criteria for ARDS. And if they do, again, follow ARDS-NET protocol. Limit your plateau pressures, higher PEEP, low tidal volume strategies, and then assessing their PF ratio. If their PF ratio is less than 200, try increasing your PEEP some more to see if it improves. If your PF ratio is less than 150, that's when they start to trigger prone positioning, and even neuromuscular blockers. This isn't as necessary anymore, especially when the 2019 study came out in the New England Journal of Medicine showing no mortality benefit for early neuromuscular blockers. However, we do use it, especially if a patient is desynchronous with the ventilator. And then if they're very severe PF ratio less than 80 or they're not responding to proning, that's when we should consider VV ECMO. So now we're going to roll into the COVID-19 era that we currently live in and talk a little bit about proning here. So this study was just published. This is a very large study about prone positioning and survival in patients with COVID-19. And they looked at 2,338 patients. And what they found was that patients that were proned within the first 2 days of ICU admission had a lower adjusted risk of death compared to those that were not proned. So really showing that proning these patients, COVID-19, is beneficial, especially within those first 2 days. And that's very similar to the criteria in the Prosiva trial, which was non-COVID ARDS. There are the theories of, is COVID-19 traditional ARDS? And I think there's still debates going on, especially when you're talking about the difference in compliances, if you have a high compliance patient or a low compliance patient, how you should treat these patients. But again, this study, very large sample size of over 2,000, found that if you prone patients within the first two days of ICU admission, they had a lower chance of death. This is just a little graph showing that the proned early group had a higher percentage of survival than the not proned early. And then this leads to my study. This is actually the first portion of my PhD dissertation. And this was from the first month of the pandemic. Myself and colleagues really wanted to assess how prone positioning affects patients with COVID-19. And what is interesting about our study is we're the first study to really assess serial prone positions. Whereas all the past literature looks at the initial prone positioning session, they see that the patient responds and labels them a responder, and they just continue proning as long as they meet criteria. Whereas my study, I looked at each individual prone session that the patient underwent to see their response, and then I tried to see if there was a difference in the patients that were successful, meaning they survived, or the patients that either died or ended up on ECMO. So again, I broke this into a treatment success and treatment failure group. And the very interesting finding that we found was that the patients that did not respond after the first prone session either died or ended up on ECMO. So this was a very, very interesting finding. Most patients responded on the first prone session. Positive response is considered a 20% increase in PF ratio. So you can see the treatment success had a 63% and the treatment failure had a 40%, both significant. However, after that first prone session and into the second prone session, the treatment success group continued to respond, whereas the treatment failure had a markedly decreased response in PF ratio, which is something that should be looked at more, especially in patients with traditional ARDS, if this holds true. I'm going to talk a little bit about awake prone positioning because we've been very involved in the awake prone positioning here at Rush University. I cannot speak too much on it because we are currently under publication, but you guys will be getting a lot of literature out very soon on awake prone positioning. But something that we have published, some colleagues in my group, is they did a systematic review of awake prone positioning in non-intubated patients. And overall, from these observational studies, we found that awake prone positioning does indeed improve oxygen. However, we didn't really see anything in mortality benefit, good or bad. So from this is when we triggered the randomized control trial of the prone positioning of hypoxic patients with COVID-19. So we did a randomized control trial at our institution, also as a multi-center, multi-country study that has completed. And as I said, I can't speak too much on it because it's currently under the publication process, but you will be seeing it very soon. However, I can say that we did have similar findings as to the awake and the intubated prone positioning that I talked about, the study that I published, whereas those patients that continually responded in the prone position during awake prone position with high flow nasal cannula did tend to have better outcomes. So stay tuned for that. We have several studies being published coming up soon. So now we get to how do we do it? How do we prone it? We know that, okay, it works. It's mortality benefit. So now we have to do it. There's several ways: manual prone positioning, or you can use specialized beds. Rotaprone is one that I think most people are familiar with. I think there's a couple other on the market, but these are the two main ways. There's currently no standard method. So some hospitals I know use the automated bed. We at Rush do manual proning. There are different ways to see the technique. So if you want, you can see the Prosiva Trial video, which is you can look up on YouTube. We actually made our own during the surge at Rush, and just a little bragging rights on it. It did get picked up by the World Health Organization and their education site, as well as our video is sitting right next to the Prosiva Trials video on Up to Date, so which is a pretty cool video to be sitting next to the landmark study. So feel free to check out our video on YouTube. This is the link to it. In terms of the rotaprone bed, so the automated bed, it's been shown to have the same effects as manual prone positioning with improved PF ratio, lower mortality when compared to supine. However, in this study, it was not compared to manual proning, but it seems to mirror the results from past proning research. If you guys are familiar with it, this is the rotaprone bed. So the patient gets strapped into the bed, and then you hit a few buttons, and they get proned. This actually studied. There was a study recently just came out this March that did compare manual versus automated prone positioning in patients with ARDS, and it was a retrospective study that looked at 37 patients. And what they found was, again, in terms of outcomes, they were similar between the two groups, the manual or the automated bed. However, the patients that were manually proned had a significantly less interruptions in therapy and significantly less complications, mostly being pressure injuries as a complication. And it should be noted that the manual prone positioning group also had a cost avoidance of over $78,000 per patient. But again, when it comes to outcomes, both were essentially the same. So prone positioning ARDS, I'm not going to go through all of these guidance, but when we're talking about how to do it, it's really what works best for your institution. You can find many stepwise approaches out there and on the internet, in the literature. It's really what works best for you at your institution and your clinicians that will be performing the procedure. So this is just one example of a stepwise approach. This here is another study that just talks about an algorithm for how to place a patient in the prone position. So again, these are readily available if you're trying to create a process at your institution. And I am happy to share all of our materials that we use. We actually created a whole prone package that I sent out all over the world during the pandemic. So I will have my information at the end of this if anyone is interested. Again, I'm not going to go through all this. This is just, again, the whole process. This is actually our process. We have a 4-phase checklist, which I have to give a shout out to my fiance, who is a critical care nurse in the MICU, who was really the leader of creating these checklists. She did a fantastic job. So ours is a phase 1, which is the pre-prone. Basically, what's the role of each person before we prone? The respiratory therapist, the staff nurse, the doctor. What supplies do we need? Phase 2 is how do you execute the prone position? And we have our steps for manual pronation as well as supination. And then phase 3 is basically what do we do once they're prone? Which essentially you just back to standard care. It's just the patient's on their belly. But there's a few things that you might have to do depending on how you choose to position the patient. And then phase 4 is basically just what do you do once you supine the patient back. And then again here, this is just something I want to highlight here. One of the most important things is the largest complications with prone positioning is pressure injuries. Because you are in one position for at least 16 hours, patients can get pretty significant pressure injuries if not taken precautions to prevent them. So again, myriad of guidelines on the literature. You're essentially just wanting to pad the bony prominences. So this is this study's recommendations: the forehead, the shoulders, ribs, knees, feet. This is the National Pressure Injury Guidelines, which this was for COVID-19. This is what they released as some of their tips. This is ours at Rush. This is our technique, and we color coded what each of these circles mean to what piece of padding you should use. So again, it's really, our process here came from a lot of trial and error. We would try something, we didn't like it, we'd try something else. So with prone positioning, we found that creating a process comes with a lot of trial and error. One of the main things as a respiratory therapist that I have been reached out to a lot is the facial injuries. So this is our process that we have came up with to protect the face from skin injury. Does it still happen from time to time? Yes, but it has greatly improved our facial pressure injuries. And really this last picture on the right is how the patient will look. We don't use the hard, sticky endotracheal tube holders. We use this soft cloth type endotracheal tube holder, as well as using foam padding to pad the face. And now while talking about how to prone position someone, something that we did at Rush, because once we started getting a lot of patients in, about 85% of them were prone. And we were at one time ventilating 25% of the intubated COVID patients in the state of Illinois at Rush. So we had close to 100 vents running at one time, which 85% of them were prone. And we realized that it was too much for the bedside staff to try to keep up with. So in a pinch, we created a multidisciplinary prone team that was led by a respiratory therapist. And really what we did is we pulled staff that weren't being utilized during the pandemic. So like physical therapy, occupational therapy, as well as OR nurses and techs, and got them trained up real quick. And we created a whole prone team. And this is just a picture of our prone team. We made a cart with lights. We even had music. Everyone knew when the prone team was coming. This is them in action. And this is some of my team. This is me here and some PTs and OTs. And this was our assignment for the day. We would go around the hospital and prone and supine patients, which really helped alleviate some of the burden on the bedside staff at the time. And from this, we sent out a survey just to assess our process of the multidisciplinary prone team. And couple of the highlight findings we found was team members noted that the more direction that came from the RT, the better organized and coordinated the maneuver was, as well as we just found that having this team-based approach was highly beneficial, especially during times of high need. We also did highlight some areas that we could potentially improve on if we were to deploy the prone team again. Who knows, we might have to again, depending on how this plays out. But really just ensuring all participants that are taking part in the prone team are adequately prepared. Maybe doing some check-ins here and there, seeing if the team members have any questions or apprehensions about coming onto the team. One of the big things was a timeout we found, just as if you were doing a procedure, just to make sure everyone's on the same page on what direction we're going to turn the patient, as well as if anyone has any concerns. And then one of the lowest scoring items that our team members would have really liked to know the patient outcomes. Because again, me as the respiratory therapist, I knew because I wasn't always on the prone team, but the people that are on the prone team, the occupational therapists and the physical therapists and OR nurses, their only role was to just go and help prone. So they really didn't ever follow up the patients. That's something that they really would have liked to do. So I think going forward is something we would do. Also, just assigning each member of the team a specific duty. That way we were a well-oiled machine. Once we got running, we would get the call that a patient needed to be prone. We'd get there and the patient would be on their belly within 10 minutes. Because everyone knew exactly what to do. I always had that airway. I'd pad up the face. One person would take care of the lines. One person would pad the body. And we would be flipped and on to the next one very quickly. So now we talk about how do you train people up? Well, we actually did this study as well at Rush. We published in 2018. And essentially all we did is we had this very sick and very handsome, I might say, patient. Just kidding, that's me. That we used to do very high fidelity training on prone positioning. So our physicians, respiratory therapists, and nurses, they came, we gave a didactic lecture about why we prone, how to prone, did a pre-test, post-test, and we did a lot of hands-on of them proning. And we found that this type of hands-on training really enhanced their confidence as well as ability to place a patient in the prone position. And this is just, again, some of our guidelines and checklists we use for that particular study. And here is the same way that we trained in COVID-19. This is one of my nursing colleagues, Liz. This is me at the head of the bed, and this is our prone position video, which again, you can see on YouTube. But again, utilizing that high fidelity and making it as real as possible, putting lines, fake Foleys, having fun with it, I think was very beneficial to train people to actually do the proper prone positioning process. And then I'm going to wrap up real quick here on really the mechanical ventilation strategy of once you place the patient in the prone position, what should we do then? Well, once we place the patient in the prone position, we should still be following those ARDS protocols, low tidal volume strategies, following the high PEEP, low PEEP, FiO2 tables, whatever you feel the patient seems to fit on. We really don't have an optimal PEEP. There's many different ways in the literature of how you might set optimal PEEP, decremental PEEP, using esophageal manometry, or just looking at compliance. There's many different ways, but really just what you feel the patient needs to be on based off of ARDS protocol. you may see your peak and plateau pressures increase immediately after you prone. This is actually not uncommon, very common and not unexpected. This is usually due to because now you have decreased chest wall compliance because your chest wall is pushed up against the bed. So the chest is not able to expand as much. Also, you talk about postural drainage. You are flipping a patient completely upside down. So you may definitely mobilize some secretions, causing increased peak pressures. However, over time, you will probably start seeing decreased peak and plateau pressures, and this is most likely due to alveolar recruitment. So meaning prone positioning is potentially helping. And then when we assess for a response, I already mentioned this previous, but really what we do at our institution, I'm not saying what we do is perfect or right, but what we do is we find that the time that the patient meets criteria, we take that PF ratio, we prone the patient based off of that, and then we wait a couple hours and draw another ABG and look for at least a 20% increase in PF ratio. I will say that in, Prosiva Trial will tell you that within, the first hour or so, the patient, you should see a response. However, in COVID, I've been seeing patients where I would get that after prone gas and it is not a 20% and I'm bummed. I'm thinking that this is not good. The patient's not going to have a good outcome. But then at hour 12, all of a sudden they respond. So I am seeing some late responders. So my recommendation is always, if you prone someone, don't be too quick to pull the trigger to flip them back if you don't see an immediate response. Give them time to recruit, and you may eventually see a response. Obviously, if you flip the patient over, which I'll talk about discontinuing therapy here, if you flip the patient over and they have a markedly reduced PF ratio, greater than 20% after a couple hours or an hour or so of stabilizing, you might want to flip the patient back over. Or if they have any complications, if they cardiac arrest, any lines coming out, self-extubation, you should obviously flip the patient back over. And then obviously an improvement in oxygenation, as I mentioned earlier, for 4 hours while they're supine. So once they do their prone session, you flip them supine and they appear to be stabilizing. They're holding their sats on minimal vent settings or reduced vent settings. Then you may hold off proning them again. I also just want to make a note that when you prone someone, they're obviously, most of the time, they're going to desat a decent amount during the flip. Again, don't be too quick to hurry up and flip them back. Give them a little bit of time to catch up and recover, and hopefully they recover well, and then you can leave them prone for the 16 hours or, again, whatever you think works for your hospital. But with that is my presentation. Again, here's my information. I am on Twitter and LinkedIn if you want to link up with me there. And this is my email address. If you're interested, as I said, we created a whole prone package with our protocol, our checklists, our order set, our video. If anyone is interested, don't hesitate to reach out. I can get that out to you. With that, I will conclude. So any questions? Let me see if I should stop sharing here probably, or come to the Q&A.
Yes. Yeah. Thank you so much, Tyler. That was a fantastic presentation and incredibly relevant and timely. Now is the time. Tyler has generously provided extra time for a live Q&A. If you have any questions or if you want any clarification during his presentation, there's a Q&A icon at the bottom of your Zoom interface where you can type in a question. That's the easiest way for Tyler to see and field your questions. If you can't find it for any reason, absolutely go ahead and just type it in the chat. We'll see it. We'll field it over. Tyler will be available here for just a few minutes. And so now's your time while you have them. Please go ahead and send any questions his way if you have them.
All right, student RT here. When I have prone patients with meeting criteria, if sats drop, how long do you wait to just tap out and turn them back? So again, that's what I was typically saying. Patients will typically desaturate when you initially prone them. Again, you're moving a very critically ill patient from their back onto their belly. I will give them a few minutes. I expect them to desat to 80%. Sometimes they even hit 70. But what you'll really see is they'll hopefully eventually start coming up. If I'm sitting there for 5-10 minutes and it hasn't even budged coming up, then I might flip them back. But really, it's their comfortability. You might need to make some vent adjustments. As I said, you might see some changes in your ventilatory pressures. You might have to adjust your PEEP, stuff like that. But I try to not urge people to flip them back too quick, because more times than not, they recover pretty quickly. Let's see here. Head turns after patient is proned. So at our institution, we do Q4 head turns. We do the swimming position, which is, the arm opposite of the way the head is facing. Every 4 hours, we just swim the patient. Again, it depends on, there's many ways in the literature. There's nothing that I know of that says one way is better than the other. But we do every 4 hours. We would have liked to do every 2 hours. But again, with our volume of patients we had, it was pretty impossible. What's the longest duration I've kept a patient proned? Probably 48 hours during COVID. That was a patient that just literally could not tolerate being supined. But unfortunately, that was a poor outcome. But there is some literature of up to 36 hours with good outcomes. So just depending, again, patient by patient. I don't know. So this question is the plan to make this a national protocol similar to ARDSnet? That sounds nice. Maybe. Yes, I'll be able to send the presentation. When is it too late to start mechanical ventilation? That is a hard question. I wish I had that question answered. I'm a proponent of when that respiratory rate starts kicking up and increased work of breathing. I think that's the time to pull the trigger. Again, there's going to be so much literature coming out on this. We already have some literature out there, conflicting literature as well. Some saying, intubate early, some late. So I can't give a definitive answer on that other than just my gut, which is watch them. If they look good, they're not breathing heavy, let them be. But if they start increasing the respiratory rate, high drive to breathe, that's, in my opinion, the time. Yes, you can prone with a Hollister ET tube holder, but just expect to have pretty significant skin breakdown. We used to do that, and that is why we switched. Let's see here. For ET tube securement, what methods are you using? We had problems with tape too tight around the neck. So that device that I showed, which I think works well, and again, I don't work for them or anything, but it's the Dale ETAD holder. It's just a cloth, and we use surgical anesthesia tape to secure the tube to the endotracheal tube holder. That, along with the padding that I showed you, has helped out a lot. Let's see here, a lot of stuff. Any tip when you are head of the bed trying to put the head and ET tube comfortable? I'm not exactly sure what that's asking, but we typically, we use it's basically the little Waffle cushion pillow that you use on for the patient in a chair. We use that to wrapped in like a chuck to absorb the secretions and just try our best. Some patients have limited neck mobility, and we just do the best we can. I already answered the tube holder is the Dale. Yes, we do. So have you had desaturations with the head turns? Yes, we have had desaturations, and it's similarly to before. We've had some desat pretty low. In that case, we just, again, always pre-oxygenate them before. hope that they come back up. It can be a daunting thing to sit and look at the monitor while they're desaturating. But yeah, they will from time to time. And that is actually the highest risk time for tube dislodgement and kinking. So you just got to be careful. More hands, the better. Why not just keep the patient prone continuously instead of just 12 to 16 hour intervals? Well, as I said, that could be something that could be coming up, as I said, with more literature coming out on this prolonged prone positioning therapy. As I said, there's a study out that did up to 36 hours. I think really the thing comes with the inability to really turn the patient a lot, and the skin breakdown that can occur, and as well as if the patient was to deteriorate and needed resuscitation, it can be a little more difficult. So it is nice to give them that little break, kind of see how they're doing. You also want to assess if the patient even needs to be proned anymore. So giving that, couple hours, 2, 4 hours, 8 hours, again, however long you would decide to assess if the patient needs to be proned again, I think is essential, because we know once a patient's lung compliance improves to a certain point, proning may not be the best thing for them anymore. So it's good to give them those little breaks. Any experience with ECMO prone therapy? No, but I have heard about it. The Italians published on that, and I give them props on that. Let me see your great presentation. Have you received patient transfers for ECMO? Consider end up avoiding ECMO? Yes, several, many. We do get a lot of ECMO, and we end up proning them. And honestly, it's speculation, but based off of some of their notes that I've seen from outside hospitals, they said they didn't tolerate the prone position. They didn't tolerate the process. So my gut is thinking that those patients, they flipped them, they desatted really bad, and they panic and flip them right back and counted them out right at the beginning. Because when we would then go and prone them, they would desat. We'd give them a minute or two to recover, and then they did just fine. And then this was the one that I think I already it's the Dale tube holder. And so we don't use Flolan anymore. We use nitric, and we do, but again, we're very stingy with nitric because we want to make sure that the patient is responding to it. So similarly to prone positioning, we look a pre and a post initiation. We look for a 10% response in PF ratio. And if we don't see that, we try to discontinue it fairly quickly, because there is a good body of literature about the use of nitric oxide and renal impairment, especially in patients with ARDS. So we would like to keep the beans working if we can. So if it's not doing anything for us, and also nitric has no mortality benefit. There's never been shown mortality benefit of nitric. It'll make your sats look nice and pretty, but other than that. Can CPR be done in the prone position? Yes, it can. There is some literature out there as well on thoracic compressions. You obviously want to be careful, but I think the best, if you really have enough people, you can get a patient flipped pretty quick. We do an incline during prone positioning. We do a 10 to 20% reverse Trendelenburg. And that is typically just to alleviate some of the swelling in the face to help prevent any skin breakdown. Let me see, that's all from the Q&A. I think there's just a couple over here in the chat. Yes, I can show my QR codes again. Any special recommendation or techniques to prevent skin injuries? So with the skin injuries, again, we have our little package. Again, I'm happy to send it to you. This was, again, a lot of trial and error. We would try something, we'd still be getting some skin breakdown. It was really just, we found that overkill is okay. Their head to toe have pads on them, foam dressings. And then also how you experience pilot deflation when proning. So the pilot balloon, I'm guessing cuff. I find that it's not much different than when the patient's supine. Obviously, when you're doing the head turns, you might get a little bit of some deflation. More so, we see a little bit of tube migration. So we actually will look at the chest X-ray before we prone, and we actually might advance the ET tube a little bit more than we typically would, just knowing that that tube might migrate about 1 centimeter or so. Yes, pre-oxygenation will always be done. So I always make sure they're on 100%, pre-oxygenate them for at least a couple minutes just to help bridge that turn. Ah, perfect. Wilma Sarmiento, I basically just answered that question. Yeah, we do check our ET2 position before we prone with the ET2, with the chest X-ray typically again, and depending on how high it is. If it's a couple centimeters above the carina, we'll probably just leave it. If it's 4 centimeters, I might advance it a couple, to 2 centimeters, even 1 centimeter. We've done a couple of times. We've also found that bigger ET tubes, believe it or not, if you really look at bigger ET tubes compared to smaller ones, they're actually longer. They're marginally longer, but especially when you're have taller patients, to really the appropriate ET tube sizes, we found beneficial, because we've gotten some transfers in, like a 6-foot man come in with a 7.0 ET tube, which is a little small for that patient. And we found that even bearing the tube, pretty much the can't be advanced anymore, and it would still migrate, and we'd have tube issues because it just wasn't able to be far enough in the airway.
Tyler, if you don't mind resharing
I'll reshare this QR
slide with your email and your QR code. We got a handful of requests there.
Yeah.
As we wrap everything up here, not only are you an expert in your topic and your field, but very well done handling almost 3 dozen rapid fire questions and answers through Q&A and chat.
Thank you. Yeah, don't feel free to reach out. As I said, the prone package has been a popular topic over the last year. It's gone to almost every continent other than Antarctica. But yeah, it's been all over the world. So don't hesitate to reach out. I'll be glad to get that to you.
Great. And Tyler, also, I know there were a few requests where people actually asked for if you could type the name of the tube holder.
Oh, yes, I can.
You just want to spell it out, or you could put it in the chat in case people are still
I'll put it in the chat. It's the Dale. It's a Dale holder, like the name Dale, like Chippendale.
There you go. So for those who asked for the name of the tube holder, it's now in the bottom of the chat.
I cannot think of the supplier of that, but if you Google Dale holder, you should have no problem finding it. Yeah. Then I don't know about CEUs. I'm not in charge of that.
No CEUs. All right, well, we'll give everyone a few more moments to take down Tyler's information, and then we're going to wrap up and let Tyler and everyone get on with their Friday evening and their weekend. Just want to say thank you again to Tyler. That was a really fantastic presentation. Some of the most engagement we've ever seen on a Friday evening for a presentation like this. So great job delivering a lot of really timely information. Thanks again.
Yep, and sit tight. There'll be more coming out very soon.
Great. Yeah, I think everyone, as you can see, there were quite a few thank yous that have also been flowing through the chats, and please reach out to Tyler so you can stay up to date with the new information coming soon.
Yeah.
We're going to go ahead and wrap up this webinar. So thank you again for Tyler. The California Thoracic Society really appreciates everyone's contributions and participation, really makes these great events for everybody. Thank you again to Fisher and Paykel Healthcare for helping make this happen. And we all hope you have a great weekend. And I look forward to seeing you in 2 weeks from now on our next Friday night educational webinar.
Thank you.